All right, it's about 11 o'clock, so we're gonna get started. Can everyone hear me okay? Okay. My name is Allie Shipman. I am the Parent to Parent Program Coordinator here at the WVU CED, and you are all here for the virtual speaker series. During these sessions, we ask that you keep your mics on mute just for respect of the speakers. Please feel free to utilize the chat if you have any questions or comments, and then there will be time for questions at the end. But today's session is Early Autism. What's next? Where we welcome our speakers, Dr. Jenna Wallace and Dr. Claire Bannock from Unlocked Potential. So welcome, Dr. Bannock and Dr. Wallace.
Thank you. Which means that one of us, which is Claire right now, are going to keep ourselves unmuted, and so we're going to be toggling back and forth with that. So I'm going to unmute myself. She's going to share her screen, and then we'll get everything started. Okay, now I'm unmuted. All right, here we go. So, are you sharing your screen, Claire? Yeah, we're working through some technical difficulties on Unlocked Potential. So as Allie mentioned, we are Dr. Claire Bannock and Dr. Jenna Wallace. We are licensed psychologists and owners of Unlocked Potential, which is a psychology practice down in Fairmont. Some of you may know us from our former lives and employment at the Neurodevelopmental Center at WVU, where we met and formed our working relationship. Are you sharing it?
Log out.
She's logged out and logging back in to be able to share her screen. Oh, yeah. So what we do as psychologists is we specialize in the assessment and diagnosis of neurodevelopmental disorders, including autism, ADHD, learning disabilities, just about anything that affects early childhood, and then providing guidance and treatment for families as they navigate that process as well. And that's kind of what Allie asked us to speak about today, starting with the beginning of diagnosis and then moving towards recommendations afterwards. So we renamed this Little Signs, Big Steps, and we'll go from there. These are just some photos of our clinic and then our two office staff. So Jessica Schrock-Heflin, who is a speech pathologist by training, does very limited feeding therapy here with us, but also is our administrative assistant extraordinaire and helps with a lot of our behind the scenes work. And then Stacy Quinlan, who is a relatively new addition to the practice. She's been with us for about a year after being a developmental specialist with Birth to 3 for 15 years. And Stacy specializes in parent education, trainings for daycares, trainings for schools, and then also is a psychometrist. So she helps us with testing for some of the older clients that we see. This is a slide that just kind of goes over what we do. We do psychological assessment, psychoeducational assessment for kids who are struggling in school. We also provide individual and group therapies for kids of all ages, and then community consultation and training. So we do a lot of training with pediatricians and pediatric specialists. We do a lot of training with parents and schools and other practitioners who are looking to learn more, especially about autism. That seems to be the thing that most people are most interested in learning more about, but also mental and emotional concerns in kids, developmental delays, and learning differences. And then Dr. Bannock has a special interest in training in sexual health education for individuals with developmental disabilities. So a couple of things about us. We are in network with the Hope Scholarship. So for school-age students who are looking for psychoeducational or psychological evaluations, we do accept Hope Scholarship funds. We're also Birth to 3 providers, and we travel all over the state of West Virginia to see kids who are under the age of 3 for evaluations for autism. We also do some work with the disability determination section and some other contract work. And we really specialize in strengths-based and neuroaffirming care. So what that means is when you come to see us and an evaluation is done for a child, we are not just focused on what's wrong and what's going badly, but also what are the child's strengths, because every child has unique strengths and abilities, and how do we then leverage their strengths to help them overcome their challenges. And so it's not just a report that outlines a diagnosis, which can be really overwhelming for families if they don't know what to do next, but we really do specialize in the what comes next and how to help build a pathway for a student or a child to succeed. So our goals and objectives today is, one, to identify characteristics of autism, especially early characteristics of autism. We are going to identify some different resources that are available for families of autistic kids. We're going to learn about the diagnosis and what to do next, and then reflect on the next steps in your journey if that's where you are as a parent, either seeking a diagnosis or just received a diagnosis.
Okay, so hopefully everybody can hear me. Um, if not, Allie, let me know because I can't see anybody's faces. I can only see the screen. So the first section we're going to talk about is early development in autism. So first thing that I like to do is talk about developmental milestones. So it's helpful to know what is kind of typical development, what are we looking for, so that way when things come up that may be delayed or different, then we know how to compare that to what should theoretically be going on. So typically what we're looking at, eye contact, a lot of people don't understand that it happens way, way early. It's one of our earliest developmental milestones that we're looking for. So we might think eye contact at 12 months old, but really at 2 to 3 months, babies should be making eye contact with you. So looking at you when you're leaning over them and playing with them. Babbling should come online around 4 to 6 months. So that just the just the repetitive, not necessarily with meaning. They're just playing with word sounds and learning how to use their voices. Around 5 to 7 months, babies should be responding to their name. So this is one that we see a lot when there's a concern for something like autism, of inconsistent response to name or no response to name. Really, that should be coming on well before the first birthday. Sitting is around that 6 to 9 month range. First words, or wrong way around the curve. Crawling is around 6 to 9 months, so usually sitting and then crawling. Imitating around 8 months, so starting to clap, maybe some waving, things like that. First word is around that 9 to 14 months range, so around first birthday, and that would be first word with meaning. So not just, the babbling of da 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 da, but looking at, dad and saying da da, or looking at mom and saying mama and not calling anyone else mama or anyone else dada. Walking is around that 9 to 18 months mark. Usually by like 16 to 18 months, if we aren't walking yet, that's especially concerning. But pediatricians are great about recognizing that and getting referrals in as needed. At 2 is when we're expecting those 2-word phrases. So want milk, go bye-bye, things like that. Cooperative play, so playing with other kids, not just parallel play, which is sitting next to a kid and also playing, but truly playing with them is usually around 3 is when we expect to see that. And then reading is closer to 5, kindergarten age. So when we think about the early signs of autism, what we're looking for is, around that 6-month mark, if we're not making eye contact or it's very limited, or we don't have very many social smiles or positive expressions on our faces, it's just a lot of crying or kind of flat, no emotion on the face, that's a little concerning for us. That's very early. But it is something that studies have been done where they look back and say, what was going on for these kids? We have videos from when they were really, really little. What's going on and what can we see that maybe over time became part of the profile of autism for that particular person, for that particular child. So at 6 months, the eye contact, limited smiling, we should be smiling well by 6 months, around the time with eye contact as well. So that should be something that we're seeing for sure by then. Around 9 months, if there's not a ton of kind of back and forth sharing of sounds, so cooing and babbling back and forth, almost like you're having a little conversation with them, smiling back and forth, other facial expressions, blowing raspberries, things like that, that kind of like imitation back and forth, we call it reciprocity is the big fancy word for it, but that back and forth, if there's not that around 9 months, then that's another kind of cue or clue for us. At 12 months, if there's little or no babbling, again, little kind of back and forth with gestures like pointing or waving, showing things. So picking something up and like holding it up for you to see, or reaching for things that we can't quite reach yet, not responding to our name by that first birthday. If we're having some concerns there, then that is definitely something that we would hope that is reported to the pediatrician and then is getting the proper referrals. That's still really early though when it comes to autism diagnosis, and we'll talk more about that. By 16 months, if there's not very many words, hopefully most kids are getting speech therapy by this point, even if it's, birth to 3 has been a great resource for the state in terms of getting those early supports in place. And then by 24 months, by that 2-year mark, if we don't have very many 2-word phrases, we're not repeating them or imitating them, even if our language is a little bit delayed, then that can be another concern that we might see. So when we think about something like autism, there's 2 kind of categories of things that we're looking at as part of the diagnostic criteria. So the first is this idea of social communication. And this doesn't actually mean your language skills. A lot of people might see like communication and automatically think, well, like my child does talk or my child's not talking. It has nothing to do with that. We do have concerns if there's some sort of loss of speech or babbling or some sort of like their social skills, they were interacting and then all of a sudden we went through a period of time where they weren't, they kind of regressed or went backwards in development. We want to know that because that's concerning for something like autism, but also maybe some other referrals are needed for other specialists. But social communication is more about how we interact with others. So we communicate with more than just our words and our voices. We communicate with our facial expressions, with gestures or signs, with our body language. And those are the things that we're really looking at. So early signs could be that avoidance of eye contact, a really clear preference to be alone. So I don't expect an 18-month-old to be, doing cooperative play. That doesn't come online until 3, but I am expecting them to show some interest in their peers, even if it is another toy that they might have, or to be curious about other people. So if there's that clear preference of like somebody walks up to you or crawls over to you and you move away from them or you turn around so you're not interacting with them, those kinds of things are something that we watch for. Limited initiation or response to joint attention. So this joint attention is a fancy term that just means if you point to something, is your kiddo looking where you're pointing and looking back at you? And so it's a 3-part gaze. So they look to the object, and they look to the person, they look back to the object, or they look at the person, object, person. And so it's both them initiating that, like pointing to something, but checking to make sure you're looking, or you're pointing to something and they look at what you're pointing at or in that direction, because sometimes it can be hard to localize exactly on what it is you're wanting them to look at, but they're looking in that direction and then they're looking back at you to say, yes, I understand what you're trying to get me to look at, or checking to make sure that you're understanding what they're directing your attention to. So we often see some limitations there when we're looking at those early signs of autism. Difficulty or lack of interest in imitating others' body movements, facial expressions, sounds. So if you're blowing raspberries or you stick your tongue out, are they sticking their tongue out back at you? Or if you make a grr angry face, are they going to try and do it back to you? Are they imitating sounds as their language is developing? Are they imitating body movements? If you take a little block and put it on your head and go, achoo, and it falls off, are they going to try and do that? They're not going to be great at doing it necessarily, depending on their age, but are they trying to do that too? Are they trying to do Pat a Cake or Wheels on the Bus or any of those kinds of songs that have those hand motions and things like that? So really looking at that imitation of other people. Other things that we look at is trouble understanding others' feelings. This is not that necessarily we're looking at lack of empathy, more so awareness of how other people are feeling. So a lot of times we can see difficulty with recognizing emotional expressions, just a trouble understanding what does that mean for that person. So if you're doing you pretend to cry in front of your toddler, are they coming over and like patting your leg or trying to give you a hug or something like that? Or are they just not even responding? So we're not expecting like a big, bear hug. What's wrong, Mom? Let's talk about it at that age. But we are expecting some sort of recognition of, overt sadness, overt anger, overt excitement, those big, big expressions of those emotions. Other things would be delayed language development or unusual patterns of language development. So language delays themselves don't automatically mean that we're concerned for autism. And you don't have to have a language delay at all to have autism. But some things that we might see are delayed language skills, but also certain patterns of development that are just different or unique. So we might jump skills. So maybe we are speaking in phrases or sentences that we're copying off of shows that we really love, Miss Rachel, Paw Patrol, Bluey, or things that we've heard other people say or things that our toys say when we activate them. But we aren't quite able to request milk when we're thirsty or request a snack when we want a snack. So we have language, but we're not necessarily using it in a way to communicate that would be what we would expect for that age. That limited back and forth of those interactions, which we've talked about, and then limited response to social interactions from others. So when other people come and try to interact with the child, how are they responding? Are they going to welcome them into their play? Are they going to run away? Are they going to ignore them? What are we looking at? And so often we see more of, if a more limited response than maybe we would expect. Maybe we're not great at sharing, and that's okay, but maybe we are having trouble with sitting near someone for proximity or playing alongside someone. And then early signs of autism at any age. So from little to older, we can see things that are like persistent repeating of words or phrases. We call this echolalia. So like an chicka 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 are a lot of ones that we hear from little kids or kids that might have more delayed language. But it can also be, people will call them scripts, but kind of repeating phrases or sentences from things that they've heard in shows, games, other people saying in their lives. Resistance to minor changes in routines or surroundings. So if you tweak the routine because you realized, oh gosh, we're out of milk, we got to run to the store, but typically this is our playtime, we might have a big reaction to that. Or if I'm not going to school or daycare today because it's a snow day or school's out for a holiday, that might throw them off. I've got some kids that are really sensitive to even, if we bump nap time back 15 minutes, it throws us off. So it can vary. So there are other kids that really remember routines a lot better than maybe you would expect for their age. So they know, okay, not just like after dinner we go and get ready for bed, because a lot of kids understand that, but even down to, at 10 o'clock every day, my child seems to be going to the pantry because that's when I typically give snack. And I haven't told them that they need snack, but they know that that's the routine. Or they know that when we turn right out of the driveway, we go to school, and when we turn left out of the driveway, we go to the park. So if we turn right, we might tantrum or get upset because we wanted to go to the park, but we're actually going to school. We also have kids that have really strong specific interests. So every child is going to have like their thing that they love. My daughter loves Bluey and Paw Patrol. Those are two of her big things. But what we're looking at is these really specific interests that kind of can almost be like a hyperfixation. So I really love Paw Patrol, but now all of my clothes have to have Paw Patrol. I can only drink from a Paw Patrol cup. I can only have a Paw Patrol stuffy. I have to take my Paw Patrol characters with me everywhere. It can be really intensive. But it also may not be character related. It could be related to, I've got kids that really love
Dinosaurs.
Dinosaurs is a big one that we see a lot. I have kids that have like unique interests. So things like water bottles, like just plastic water bottles, and really loving to kind of collect those and like look at them and watch them and just showing a lot of interest in that. We might also see repetitive behaviors. So people think a lot about like walking on tippy toes or flapping hands, rocking or spinning. But we might also see pacing, or if you watch a child long enough, maybe you see that they have climbed up onto the sofa, walked across, jumped off, ran over, hit a toy to activate it, and then come back and done the whole thing again. But it's kind of drawn out. But if you watch it long enough, you're like, oh, we're kind of on a circuit. We're getting a little repetitive in this behavior. So it doesn't have to just be something they're sitting there doing with their body or standing there doing with their body. It can also be a bigger series of actions. Unique ways of playing. So lining things up, being really particular about how things are organized, fixating on parts of toys. So instead of playing with a car, we flip it over and we just spin the wheels. Or if we have an airplane, we just spin the propeller. If you have a Barbie house with an elevator, the elevator's going up and down on the Barbie dream house. And then playing with household items instead of toys. So not a kiddo that just like you're cooking, they get in, they want to like pretend to cook too, but maybe they're getting into your cabinet and they're lining up or stacking the cans, or they're getting into the bathroom and pulling out the Q-tips and like grouping them or something like that. And then sensory sensitivities, so unusual or intense reactions to certain sounds, so loud noises or really particular sounds are bothersome. Smells, we don't usually see at a young age, but there are kids that have more trouble with smells. Tastes, being a really picky eater, being a kiddo that babies put things in their mouth, they mouth things, that's typical. But times when we've kind of come out of that age expectation of mouthing objects, but we're still doing it. We're still putting toys or things in our mouths, or pica. So we're eating things that aren't food. We're eating parts of toys. We're eating dirt and rocks off the floor. We're chewing up our shirts and like eating and ingesting the threads. Textures, so that can be anything related to clothing textures and how it feels on the body, seams of socks, tags, things like that. It can be textures that we really love, so maybe slime or fleece blankets or something like that. Things that we don't like the feeling of, so sticky, messy hands, certain textures of certain toys. The feeling and sensation of water or hair washing or haircuts, brushing teeth, all of those kinds of things. And then also looking at things like deep pressure. So is the child someone that really loves deep pressure, tight hugs, heavy blankets, anything tight or heavy on their body? They're running and crashing real hard into the wall or the sofa to get that hard input on their body. Or kids that are totally anti-deep pressure. Don't put a blanket on me, don't touch me. So it can vary. Lights and colors that we really love to look at or love to watch. So there are certain types of lights or toys that light up that we like to watch, things that spin. Are we holding things up close to our eyes because we want to see all the details of them, because we're really invested in like what all the little, like the tiny, tiny little things that most people don't notice. So early diagnosis of autism, when can we diagnose it? So for some children, they might show signs as early as 12 months, but there may be other kids that don't show signs until 24 months or later. So it can really vary. We know that with the assessments that we have, 12 months is the absolute earliest that we can reliably diagnose. I would say closer to 18 months to 24 months is typically when would be the earliest that we typically would diagnose. The average diagnosis age is usually, was it like 4 to 5 now? And part of that is based on access to resources and things like that. So some kids with autism are gaining new skills and meeting milestones until that 18 to 24 month range. And then they might stop gaining skills. So they just kind of plateau, or they lose skills that they had before. So they regress. And so this isn't like we're working on potty training and then, we were doing great for 2 days and then for 3 days, we're not doing great. This is like, we had the ability to speak. We had 10, 20, 50 words in our vocabulary. And all of a sudden we have no words at all for a period of time. It's not, well, they said milk for a few weeks. They don't say that, but now they do say water. We're looking at a complete regression in those skills. We're looking at, especially regressions in motor skills is really concerning. So if we lose the ability to walk, that's a more significant concern. Most children can be accurately diagnosed by somebody that has the background and the training as early as age 2, typically. But like I said, we're pretty good at that 18 to 24 month mark. Feeling pretty comfortable for some kids. Some kids, we will say, okay, let's take a pause. Let's get some more interventions for the next 6 months or so, because we're not going to just hurry up and wait. We're going to hurry up and intervene. And then we'll come back in 6 months and see how we're doing. So things to remember: signs and symptoms of autism are not black and white. It's not all this and none of this. It's very gray and nuanced, and every kid is different. So the next box, if you've met one person with autism, you've met one person with autism. I've met a lot of kids and a lot of people with autism in my career and in my life. And while there may be similarities between the different people that have autism, no one is a copy and paste version of the next. Autism is more so a pattern of differences, as opposed to something that's wrong or a deficit. It's just a different way that that particular person learns and engages with the world. And the diagnosis can help us guide treatment recommendations. So instead of doing your late night Google parent anxious searches of like, what do I do? And having a million different results, getting a proper diagnosis like autism or whatever could be going on is going to help narrow the scope of like, okay, this is what I need to look at. These are the things that are going to be most helpful. Instead of just throwing a dart at the board and hoping it sticks, now I have an idea of where to go. And there's no permanent autism record that follows a child. So we have some families that might get concerned, like, okay, this diagnosis is going to follow them forever. But that's not a thing. There's this whole idea, I don't know where it came from, but I know growing up, people would talk about your permanent record is going to follow you from elementary school to your job. And that's just not a thing. If you go to a new doctor and you don't get your medical records sent over, then they're only going to know what you tell them. So that's the other piece to all of this is there's not like this record that's going to follow. The school's not going to know your child has autism diagnosed unless you tell them, or they diagnosed it. So just things to keep in mind. So if you have concerns, what do you do? So a lot of people feel uncomfortable saying the word autism. It's a big word. It sounds scary, but it's not bad. It's not a curse word. It's not a bad word. You can share the concerns that you're having and ask for a referral for an evaluation. If your child's under 3, you can get that evaluation for free, likely in your home through Birth to 3. If they're older, you can ask for a referral from the pediatrician to an experienced provider that can do an assessment. Trust your gut. So well-meaning people will minimize concerns. They might say like, oh, he's just a boy, or my cousin didn't talk till he was 7 and he's fine, or she's just shy. But if your parent gut, if your caregiver gut is telling you like there's something more here, try to push forward and get that evaluation. Don't wait and see, as I already said, intervene and see. We are not fans of waiting and seeing because then kiddos can miss out on any supports that would be helpful, even if they don't have autism. Most therapies don't need a diagnosis to start. You can read books, you can listen to podcasts, you can reach out to other parents for ideas. So there's a lot of different things that you can do, even if you aren't necessarily ready to start seeking out formal supports. Keep records, track concerning behaviors or habits that you're seeing. You can use the Notes app in your phone or a notebook, but keeping detailed records is really helpful when we have concerns because then the providers can look back and say, okay, is there a pattern here? Are we seeing things that maybe are consistent with something like autism or something else? And you've got all this great data to support that. Seek an evaluation. So if you have concerns, do not wait. Seek out a reputable provider that has experience, not just in diagnosing, but also what are the next steps? Because yeah, it's great to get a diagnosis, and that will open some doors, but what are you supposed to do with it, right? If you go to the doctor and you're getting a diagnosis for yourself about some medical issue, and they just say, okay, here's your diagnosis, you have, I don't know, colon cancer. Okay, well, but what are we going to do about it, right? That's always, you want to know what's going to happen. Like what meds do I need? What's my treatment regimen, whatever. Same thing comes with mental health diagnoses. So if it's autism, if it's ADHD, if it's anxiety, what are we going to do? It's great that we now have a term that will open doors, but what do I do with it? And so that's the big piece. And then get hearing checked. So even if you don't have concerns, a lot of evaluators want to know if hearing's been checked, because if we're having trouble responding to our name, we have a language delay, we have trouble with social interactions, we need to make sure we can hear. That's a pretty low stakes thing that we can check first. We always like to rule out medical concerns when they might be popping up to make sure that, you know, if there's something treatable, we can treat that and then see if we still have concerns. Because we have seen kids that have difficulty with hearing. They go to audiology, maybe they get tubes or something like that, and then all of a sudden they're a totally different kid. We don't have the same concerns that we had. So it's always good to get hearing checked, even if you think that they can hear. Just good to see audiology for that. So in terms of evaluation and diagnosis, when we're doing diagnoses, we're not just going in and saying, okay, I'm ready to see autism. I'm only going to look for autism. I'm not going to look for anything else. That's unhelpful because it may not be autism, or it may not be just autism. So the things that we're thinking about when we go in are speech delays, something called global developmental delay, which we'll talk about, anxiety, sensory concerns, and behaviors. So with speech delays, we're looking at, we're getting a extensive history of what has language development been like, when were we babbling, when were we using our first word? Excuse me. What signs are we using, if any? How are we communicating non-verbally? How are we understanding what other people say? So expressive language is what we can get out in some way, signs, words, whatever it might be. Receptive language is what we understand when other people talk to us or gesture or whatever it might be. So those are two different pathways in the brain. And just because somebody can talk doesn't mean that they can understand what you're saying or vice versa. So we're doing an extensive kind of deep dive into what's going on with their speech, over time and that development. Global developmental delay is a term that essentially means we're seeing delays in 3 or more areas of development. So that's going to look at communication skills, cognitive or learning skills, adaptive behavior, which is like self-help skills, feeding yourself, helping with dressing, potty training, those kinds of things, and then motor skills, both fine motor and gross motor. And there are times when global developmental delay can be an early sign of intellectual disability, but that's not diagnosed until at earliest closer to 5 or 6. So global developmental delay is a diagnosis that can last until the 6th birthday to help us make sure that we're getting the right supports that we need through therapies or otherwise. And then at that time, we can reevaluate and say, okay, what's going on? We can do a more formal cognitive assessment like an IQ test or something like that to get a better sense of that child's learning patterns. With anxiety, we're looking at things like separation anxiety, trouble in crowds, being pretty wary of new people, not wanting, being more maybe a shy kid, maybe being irritable. So some kids show anxiety through irritability, and then also PTSD. So is there a trauma history there that we need to be keeping in mind? From a sensory perspective, we can see sensory concerns in autism. A lot of people think that if a child has sensory concerns, then that means that they automatically have autism, but that's not always the case. We can see sensory concerns as their own thing, but they can also be part of other diagnoses. So that's just a piece of the puzzle for us as we're coming up with what could be going on. And then behaviors. So trouble with non-compliance, tantrums, refusal. So not just that they have those, but what are the triggers for them? How are they responding? Are there any skills that parents and caregivers have found to be helpful when those behaviors happen? So these are all things that we're looking for because these could also be explaining what's going on. So in terms of differences between these, if you have a child with just a speech delay but not autism, their nonverbal communication skills are going to be pretty developmentally appropriate. We're not going to see a bunch of repetitive behaviors like body movements or play that are getting repetitive. We will still have the expressive language delay, but those nonverbals like eye contact, use of gestures, signs, facial expressions, and recognition of facial expressions, all of that will be appropriate for their age. I kind of liken it to if you've ever lost your voice and you're trying to do everything you possibly can to communicate with people. That's similar to what I would see in a child that just has a speech delay and no concern for autism because they're trying to find other ways to communicate with you. Global developmental delay skills are typically evenly delayed across the board. So nonverbal skills are right on target with where they are developmentally. Might see some repetitive behaviors because we can see some repetitive behaviors in kids that are younger, like babies might have certain things that they do repetitively and then kind of outgrow. But what we're looking at when we look at skills across the board is pretty even delays, no kind of like strengths or specific weaknesses. In terms of anxiety, children that have anxiety and not autism are typically able to engage in social interactions when they feel comfortable or if they're in a familiar situation. But those social interactions are more challenging if it's a situation that is overwhelming for them or it's a new situation, new people. So social interactions that can be problematic, but we're still not seeing those repetitive behaviors. So we can still have trouble with peer interactions or social interactions, but we're not seeing a lot of the repetitive play or body movements that we might see. Sensory concerns. So sensory concerns are often significant for a child that has a lot of sensory concerns, makes sense, but social difficulties and repetitive behaviors are not as concerning. So yeah, I'm very sensitive to loud noises and I'm a picky eater and I don't like the texture of this on my body and all of these different things. But socially, I'm on target for my age and my developmental level. There's not really any I play with a lot of different toys in a lot of different ways. I'm pretty flexible and easygoing as long as it's not a sensory issue. So that would be a child that has more just kind of a sensory difficulty. And then behaviors. So behaviors can impact social interactions, right? If I'm having trouble with staying calm, then I might get upset in a social interaction with another kid and push, take a toy, yell. And that's going to make social interactions inherently challenging because other kids don't want to be on the receiving end of those actions. But when that child is in situations where they're not having behaviors, you're seeing really typical social skills. Autism is a skills deficit. So it's not something that we have sometimes and we don't have other times. It's like diabetes. If you have diabetes at Walmart, you have diabetes at home. Same with autism. So if you're having behaviors at school, but no behaviors at home or vice versa, it may not be autism. So the assessment process for little kids especially is typically a team-based approach. So things like birth to 3, where we have multiple providers on a team, or some hospital systems will have team approaches in how they kind of structure their clinics. When we were at the Neurodevelopmental Center, our team consisted of neurology and psychology, and then we would also consult with speech, OT, PT as needed, and any other providers in that child's life. But kind of looking at it from all angles, where we would be observing play, observing that parent-child interaction to see how does that child interact with their caregiver. How are they interacting with the clinician? So we're typically a new person. So are they comfortable with parents and not comfortable with us? Are they overly comfortable with us? Are they just coming right over and sitting down in our lap and like, okay, we've instantly made a new friend. So we're watching all of these interactions, and then there's some standardized assessments that we might give. So you might have heard of like the ADOS or the CARS. There's some other things that we might give at times depending on age and concern, but there's always going to be some sort of standardized assessment that we're giving as well. And then for the feedback, kind of talking about what we've seen, what's going on, we're going to talk about what we noticed, what we observed, what those scores say from that standardized testing, what the diagnosis is and what it means for that child, and then what we recommend to help your child grow moving forward. So we're always trying to make sure that we have a well-rounded discussion. We also recognize that getting any diagnosis like this is really challenging. So personally, we try to have a follow-up visit a couple weeks later, if possible, to talk again, because we recognize the second that we say, you know, your child has autism, a lot of people will shut down because that's and not really remember much of what else we've said. And it makes incredible sense, and we'll talk about that. But we try to be really mindful. So we provide a lot of resources for our families, which you guys will get access to today. And just try to be respectful of that emotional side of the process for families as well. So autism, what is autism? So we talked a lot about what we're looking for, differences we might see, but when it comes to autism, there's these 2 categories that we're really looking at. So social communication and behavior patterns. So for social communication, we're looking at your ability to develop and maintain relationships. So for little kids, that could just be like back and forth. It could literally be a back and forth of rolling a ball or sharing toys. Well, I guess that also goes into social emotional reciprocity, but also how are you doing with being able to initiate interactions with others, respond, maintain that play or maintain that interaction over time? As kids get older, it's things like conversation or play on the playground or playing a game. Are they able to develop solid friendships that they can maintain over time? Are they able to develop conversations that they can then maintain, or do they just fall flat? Things like that. And then nonverbal communicative behaviors, which we've talked a lot about: eye contact, facial expressions, gestures, both using them yourself and recognizing them in others at an age appropriate level. Behavior patterns are going to be things like repetitive speech sounds, repetitive body movements, repetitive use of objects. So using a toy in the same way every single time, like this toy only has one job. Trouble adjusting to changes or new routines, or remembering those routines a lot better than other kids. Over or under reactivity to sensory input, or being very interested in exploring objects or toys from a sensory perspective. So holding this up to the ear to hear better, looking at things really closely because they look neat. And then these hyperfixations are really strong interests in things and ability to hold focus on them for a long period of time. So I just saw a child recently that loves Magna-Tiles, and he's 2.5, and he can play with Magna-Tiles for an hour. Typically, I'm not expecting a 2-year-old to do anything for an hour, maybe sleep if you're lucky. But that was telling to me. If he really loves these, that's great. And he loves them so much that he can play with them for an extended period of time beyond what is age expected. So when a diagnosis of autism is provided, there's a level of support that goes with it. And there's a lot of misinformation and misunderstanding about levels of support. So the level of support is not intended to be a severity level. It's intended to signal how much support do we need to be providing to a person at this point in time. So the levels are 1, 2, and 3, very fancy. So level 1 just means you're requiring support. Level 2 means requiring substantial support, and level 3 means requiring very substantial support. So 3 would be the most amount of support needed, 1's the least amount, and 2's in the middle. A lot of kids when they're younger may end up with a level 3 diagnosis. We're looking at, if we're minimally verbal, if we're not really engaging with others, if we're spending most of our time engaged in more repetitive or stereotyped play. But what we know about these levels is that with interventions and supports through therapies and otherwise, they can come down because the child is able to be more independent, more flexible, and doesn't need as much help in those certain domains. So they can vary over time. They can go up sometimes too if there's like a big significant event in their life or something like that. But most of the time I can't promise you that they'll go down, but they can shift. So recent stats for autism, the most updated statistic is that 1 in 31 children in the United States have autism. We're still learning a lot about why, but what we do know is that genetics plays a big role. All ethnic and socioeconomic groups experience autism, so it's not just something that only happens for one ethnicity or one socioeconomic group. And then about 1/3 of kids with autism grow up to have an accompanying intellectual disability. So difficulty with learning and adaptive functioning and may need additional supports. So I'm gonna stop sharing my screen so Jenna can share her screen to talk about what to do after diagnosis.
And we will also happily answer any questions if at this point, now that Claire has gone through diagnosis itself, if you have any questions about that, please feel free to unmute and ask. Nobody.
I will just say quickly that I appreciate you guys so much. A year ago, you helped get my daughter diagnosed, and I felt like I was crazy, and no one was on my side, but you guys do phenomenal work, and I just wanted to give you praise for that.
Thank you so much. That means the world to us. Honestly, you don't get a lot of feedback when you work in the medical field or the mental health field, and it really, that's why we do what we do, is to be able to help families access the services that they need and have a path forward and a clear understanding of what's going on with their child. Okay, well, we're going to talk about what to do next, which is usually the biggest question. I have a lot of times by the point that parents come to us, they've either thought about autism as a possible diagnosis, or they've concluded that their child does have autism and they know that. And their biggest question is, what do we do now? Where do we go from here? Which is a really important question. The first thing is, and Claire and I talk about this a lot, process the information however you need to process it. As a parent, a lot of times there is pressure on us to do more and to be quick and to get every single thing your child could possibly have or need. You need this therapy, you need that therapy. You're often handed a huge packet of information at the point that your child is diagnosed. My child was diagnosed with a medical issue, and I literally was given a textbook at the moment that she was diagnosed. And so there's a lot to absorb. And it's really important that you take the time that you need to be able to process the diagnosis and the information that you're being given. There is no timeline that you have to put on yourself in order to get to the point that you need to get to. There's also for some families, there's a grief process that goes into learning about a diagnosis for their child, regardless of what that diagnosis is. And so there can be a lot of emotions. We put up the Kubler-Ross grief cycle because there are cycles of time where you're going through feelings of denial or disbelief, or feelings of sadness and despair, being angry. Why did this happen? What is going on? Bargaining, maybe trying to negotiate with God, or with struggling to find meaning of why this could have happened to your family. And then there's also feelings of acceptance. And sometimes that acceptance doesn't last forever and you cycle back through. These are a cycle for a reason. And if you are experiencing any of those things, it does not mean that you do not love your child, or that you are not accepting of your child. We all, when we have babies in our belly, or when we go through the adoption process, or whatever it may be, have some sort of vision of what life will look like as a family. And maybe that means that your family system will stay together, and you and your spouse will do well, and you'll raise this baby together. And sometimes things change, whether it be divorce, or the child has a diagnosis, or you have your own medical concerns, and it's not what you expected. And so just know that if you're feeling these different feelings, there are people that can help to support you, and also you're not alone, and there's nothing wrong with you. You'll see the QR code here on our website. There is a community resources page. It's specific to West Virginia and surrounding areas. So we do have Maryland and PA resources, but we really specialize obviously in working with West Virginia families. So there are a lot of different community resources that you can access on our website. And I know the CED has a really beautiful packet similar to ours, but just resources that you can get into. The other thing that we put up here is don't Google that. And I know Claire mentioned earlier, like now you do have specific things that you can Google, but just be aware that when you put something in your search engine online, there is no vetting of that information. So when you hear that your child has autism, you could Google a million different things, like Brussels sprouts cure autism, Brussels sprouts cause autism. Even now, unfortunately, there's a lot of information out there that puts a lot of blame on parents for what they did or did not do that has caused their child's autism diagnosis. But please know that there are reputable websites that you can access, and a lot of those are on our resources page where they do vet the information that is out there. Another thing to think about is, with what do I do now, is to find the connection with your child. Remembering that there's nothing wrong with your child, but he may need accommodations and adjustments to help him or her thrive. To focus on progress and not perfection. And then to think about how can we use the things that we know our child is good at and is interested in, and then help to teach them new skills during play. So thinking about how often autistic children are being told to conform with their neurotypical peers. How often do we spend time trying to get them to share, trying to get them to engage in specific ways with creative play or other types of play? I want you to think about that, and it's important for you to continue to help your child to learn skills so they'll do well at school and play groups, etc. But also, how can you spend 5 minutes a day playing the way your child likes to play, or encouraging the other children in your home to play the way that your child likes to play? How can we show interest and excitement in the unique interests of autistic children, so that then they're even more motivated to play in different ways because they know that you think that what they're doing is valuable and interesting? If your child's lining up everything in the house, how do you start lining those toys up with them and labeling it? Oh, mommy's going to put the red one beside the blue one. So you're creating a language-rich environment that's also related to the thing that your child enjoys doing. If they love Thomas the Train, then Thomas the Train is going to have lunch with us today, and we're going to create that different scenes with Thomas. We're going to use Thomas to make sounds like choo choo, and we're going to continue to kind of incorporate your child's interest into play. Find your people. And so this is an example of finding your people, and the programs that the CED has with Pass for Parents and Family to Family, being able to find groups of people who are in the same life circumstances that you are in is an invaluable resource. So we could tell you all day which ABA therapy programs, which speech therapy programs, whatever it may be that are out there for you to access, and those are available on the website. But the people who can actually tell you what that looks like and what their experiences were with that center, how their child is doing after being in a program, those are the people that are an invaluable resource to you. And huge kudos to the parents of our state who are out there doing this work. And here you'll see some Facebook pages here, ABCs of Autism, What We've Learned from Bella. That's a group that's down in the Charleston area. Autism Moms Connection is the group that's more like Fairmont, Bridgeport, Morgantown. Autism Support Morgantown is a very active Facebook page. And then Unpuzzled Parents Connect support group over in Wood County area. And all of these parents that are leading these initiatives are doing incredible work to try to help parents feel less alone. Over on the left side of the screen are some pictures from the Autism Caregivers Conference that we just hosted here in Fairmont. It is not our baby, it is not our project, but we are just here to offer space and resources. Ramsey Stacy has really taken the lead in this project and being able to every year have a place where caregivers can come and learn more about parenting children with autism, but also, and probably more importantly, connect with each other and learn more about the true lived experiences of other people. So those are a lot of amazing resources. Then when you think about what do we do from a therapeutic perspective, we encourage you to think of it as like finding your support staff. So if you are the executive director of the board of your child, right? You are in charge there. How do you find the rest of your board members and the people who are going to be your support staff as your child moves and progresses towards their goals? That board is not always going to look the same. You may have periods of time where you really need the speech therapist to be up in leadership and really helping you with different aspects. And then there may be times where your speech therapist is still there, or, maybe you're taking a break and you need your OT to step in. So these are just different people that may be involved in your child's team. Speech therapy obviously can help with things like speech articulation and how a child pronounces words, but also can help with building vocabulary. And then as children have greater vocabularies, speech therapy can help with conversational and social skills. So not just do you have language, but how do you use your language, and how can you build relationships with people using language? Obviously, they can also help with assistive communication, like AAC devices or PECs or other strategies that will help your child to be able to communicate their wants and needs. Occupational therapy can be incredibly helpful for sensory avoidance or seeking. So those kiddos, like Claire was talking about earlier, who really need a lot of sensory input or really avoid different sensory input. Motor concerns, especially fine motor skills, delayed self-help skills like potty training and being able to feed yourself with utensils. Mental health providers can be really helpful with learning social skills, addressing behavioral and emotional concerns, and parent training and guidance of when this happens, how do I handle it, or what should I do? Feeding therapy for those extremely picky eaters, as well as for kids who have oral motor actual deficits that impact them, like choking and gagging when they eat, or trouble with kind of using their tongue and the movements. And feeding therapy can be done by speech therapists, occupational therapists, a combination of the two. There are some, like at the CED, the feeding therapy program that includes behavioral specialists as well. So there's a multidisciplinary approach there, or it can be done with one practitioner at like an outpatient office or through Birth to Three. Physical therapy can be very helpful for motor movements, clumsiness, hypotonia. So a lot of kids who have autism will also have that hypotonia or lower muscle tone Tone is a signal that's sent from the brain to the body about your kind of awareness in space and how to use your posture. So it doesn't have anything to do with your child's strength. It's more to do with if they're wobbly or if they kind of slip through your hands when you pick them up. So physical therapy has been shown to be incredibly helpful for kids with autism. There's been a lot of recent studies done on that. And then ABA therapy, so applied behavior analysis, which the best way I can describe ABA is taking big behaviors, breaking them into small steps, and using reinforcement or positive reinforcement over time to help build those big behaviors. Behaviors don't have to be tantrums or negative behaviors, which is what a lot of people think of when they hear ABA or behavior therapy. Anything that we can observe is a behavior. So communication is a behavior. Sitting in the chair is a behavior. Using the potty is a behavior. ABA can build behavior plans for just about anything that you can think of. And so it can be incredibly helpful for a lot of people. Then when you're thinking about your board or your support staff and working with your child as they're growing up and getting older, there are some specialists that can be involved in the care of a child with autism. That doesn't mean you're going to need every single one, but here are some ones that you may need. Neurology is on the list. The things to think about when it comes to neurology and autism. So if my child has a diagnosis of autism, how do I know if I need to see neurology? A couple of things. If you have concerns for possible seizure activity, so if your child stares blankly and you can't get their attention by touching them or waving in front of their face, or obviously shaking and jerking or convulsive activity, that would be a reason to see neurology. Developmental regressions, so your child, as Dr. Bannock was describing earlier, was making progress and they suddenly stopped or went backward. And then like motor concerns, obviously, if you have concerns for things like cerebral palsy or motor weakness, motor stiffness, those would be things to see neurology for. Sleep medicine. So a large number of kids who have autism will have some sort of sleep concern. Sleep medicine can be incredibly helpful. And that doesn't mean sleep medicine like a medicine, the pill. It means sleep medicine like the specialty of doctors who help with sleep. So if your child is having trouble falling asleep, if it takes longer than 30 minutes to get them to fall asleep at night, if they snore, if they're a very restless sleeper, if they persistently wet the bed past, the age of 7, really, but even that 5 to 7 range, if you have concerns about that, sleep medicine can be a helpful doctor to bring on board. A lot of children, up to 80% who have autism, will have some sort of GI issue. So gastrointestinal issues like constipation is a very common one, or loose stools, unexplained vomiting. So any issues with digestion, you could get GI on board. ENT for kiddos who have ear infections a lot or recurrent strep throat, snoring, choking or gagging while eating, or a lot of really significant sensory aversions with eating. ENT might be good to bring on board. Psychiatry can be very helpful for co-occurring mental health conditions. So there is not a medication, and psychiatrists, the difference between a psychiatrist and a psychologist, psychiatrists are medical doctors who go to medical school and then they get additional training and expertise in mental health concerns and neurodevelopmental disorders for the ones who specialize in child and adolescent psychiatry. So they oftentimes are the prescribers of medication. There is not a medication that works on the core symptoms of autism, but there are, when you think about like anxiety and autism or aggressive behaviors in autism, about 60% of kids who have autism will also have ADHD. So psychiatry can come on board to help with other factors that might be impacting a child who has autism. And then genetics. So we do know that there is a large genetic component to autism, and families might be wondering, is there some sort of genetic syndrome or finding that would help us to better understand our child's diagnosis? And genetics would be the specialty to bring on board there. A couple more slides. The last thing with what do I do now? Presume competence. And if you've never heard that phrase before, what it means is always assume that your child knows what's going on around them. Non-speaking doesn't mean non-hearing. There's no one way to measure your child's intelligence. And so assuming that they are making progress, assuming that they are learning and that they understand what is going on around them is going to help you and them to continue to navigate this process. Don't speak badly about them in front of them, just like you wouldn't with any of your other children. And don't allow other people to do the same. And, really focusing on their strengths, that doesn't mean that you're in denial. It means that you are a parent who is focusing on their strengths and building on those strengths. And similarly, expect progress. Your child's progress might not look like other children's progress. It may not look like your other children's progress, but celebrate every single success, even if they're small or feel small to you. Don't let anyone tell you what your child will or will not be able to do. And don't be afraid to make a change or pivot. If you have decided that this is the program that we're going to join, but then you feel like that program is not what's best for your family or your child, don't be afraid to make a different decision, as long as it's one that you have thought through, and hopefully you've had your board on board with you to be able to talk through different options for you. Autism Speaks has a first 100 days toolkit, and this is the QR code for it. You can also look it up online. It is a really beautiful resource. It's over 100 pages, but it helps to explain all of the things we've talked about today, as well as different options and resources for care. And then just as a plug, if you are having difficulty with your child's aggressive and challenging behaviors and are looking for a parenting group and coaching series, this is something that we are starting this fall. Over the summer, we had a lot of parents reaching out to us and saying, we're really struggling with our child's behavior. We haven't been able to find anywhere that we can just learn more about how to manage those behaviors. And we also know that it's really hard for parents to make something like an in-person group or even these virtual series work in their daily schedules, especially when they're working with their child's complexities. So this is going to be an online training, but we'll be recording every session and making it available to families immediately after, so that even if you cannot make it in person, you'll be able to attend virtually. Here's the link to that. The link is also on our website, unlockedpotentialwv.com, under the events page, if that's something you're interested in learning more about. Okay, it's 12 o'clock. We did the content within an hour, which I'm really impressed by. Hopefully we weren't talking too quickly, but we will open up the floor for questions. Allie, if that sounds like a good next step. You're muted.
There we go. Yeah, that's fine. Questions. If anyone has any questions, feel free to ask them, unmute yourself, ask them, or if you were more comfortable putting them in the chat, we can do that too. No questions? Does anyone want to do they have a story they want to share maybe? About something that maybe your experience or why you're here at this session? Okay.
So another thing that everyone can keep in mind is, obviously our contact information is on our website. Even if you are not looking for services right now, or if you have questions about anything we've asked, please feel free to send us an email or give us a call. We're happy to talk and help, even if we're not providers that you need on your board right now. But yeah, please continue to talk with each other and continue to grow this. You're doing a great job, Allie. We are hosting a sensory-friendly trunk or treat here at our office in Fairmont, which is 1000 Technology Drive, on Sunday from 2 to 4. So if you have kiddos that love to trunk or treat and you want to come and join us, we would love to see you here.
Okay. All right. If nobody had, there's something in the chat.
Yeah, also I'll read it. Have you all seen
Okay.
any increased incidence of autism diagnosis with or followed diagnosis with genetic connective tissue syndromes? I actually wrote a paper with some of the folks from over at WVU a few years ago about connective tissue disorders and increased prevalence of anxiety disorders and neurodevelopmental disorders. So I think and the paper didn't get accepted, so I can't send it to you. It just it's out there in the world and in a revise and resubmit. But what we did learn is that oftentimes it's kind of like this chicken or the egg thing where when we have diagnosed autism, then we start to pay attention to some of the connective tissue issues. So you're thinking about Ehlers-Danlos syndrome, and others like that. And the families really do oftentimes learn about those when they've come in for some other kind of neurodevelopmental concern. So I don't think the prevalence is going to be very accurately recorded right now, but we are seeing that association, that correlation between the two, and families even becoming more aware of connective tissue disorders. It's helping us to kind of understand the connection, but definitely yes, with mental health concerns, that's been broadly shown that connective tissue disorders and mental health concerns are highly correlated. Yeah, I think so too. Very interesting. And I think any kind of birth defects too. So we think about especially midline defects. So if there's changes in the way the brain was formed, in the facial features, and the palate, in the heart, all of those kind of midline defects, the kidneys, the tummies, those kiddos are at higher risk for neurodevelopmental disorders, generally speaking. Now, is that because of a genetic syndrome or is that because of their kind of neurobiological development? It's hard. I don't know the answer to that personally, but we certainly see that connection oftentimes.
Anything else? Okay. All right. Well, I believe if anyone else has any questions, they can email you. Your email is on the website, correct?
Yep, I'll
And
put it
then
in the
if
chat too.
okay.
And Claire and
So
I
she'll
both
put-
check this, so it's just the easiest way to get both of us. It's info@unlockedpotentialwv.com.
Okay, perfect. All right. Well, if there's no other questions, thank you so much for the wealth of information and for presenting today for us. We appreciate it.
Thanks for
All right.
having us.
Yep.
Bye,
Have a
everyone.
great day.
Have a great
Bye-bye.
day.